Hi, everyone. Welcome to everyone here in the studio with us and to everyone who's joining us online. I am Malika Marshall. I'm a medical reporter for WBZ TV and CBS News, but I'm also a practicing physician at Mass General and an instructor at Harvard Medical School. And I am so thrilled to be your moderator here today for today's discussion, where we will hopefully be answering your questions about anti-obesity drugs and sort of how do they align with longstanding advice about nutrition and exercise, mental health, and positive body image. So we have four wonderful panelists here. We've got Bryn Austin, who's professor of social and behavioral sciences at the Harvard Chan School. We have Caroline Apovian, who's an obesity medicine specialist and co-director of the Center for Weight Management and Wellness at Brigham and Women's Hospital. We have Uma Naidu, who's director of nutritional, lifestyle, and metabolic psychiatry at Mass General. And we have Fatima Stanford, who's an obesity medicine physician scientist also at Mass General. So I'm actually going to start with you, Caroline, and we're going to jump right in, and we really want to sort of explain initially how drugs like Ozempic and Wegovy and Mounjaro actually work. A lot of people refer to them as GLP-1 receptor agonists. You may correct us on that, but can you just give us an idea of exactly how they work and how they differ? Because it sounds like some have been approved for weight management, some have been approved for diabetes. What are the differences?
That's a great question, Malika. So we call them anti-obesity agents. They are analogs of naturally occurring gut hormones that are secreted from the intestine, and they are secreted in response to food coming in. And so these hormones then go to other organs and the brain and tell the brain whether you've eaten enough or not. And we've learned all about them from studying how bariatric surgery works, which, as you know, alters it's surgical procedures that alter how the intestines, how food flows through the intestines. And we've learned that some of these gut hormones are secreted earlier in the trajectory of food, and you get satiety earlier and with less food. And so, but they also increase the secretion of insulin. And so that's why they were initially approved for treatment of type 2 diabetes. And then later on, scientists realized that they help you lose weight. And so that's why we have these dual mechanisms. Now, what are the differences? We have two great drugs on the market currently, semaglutide and tirzepatide. Semaglutide for diabetes is Ozempic, semaglutide for obesity, Wegovy, tirzepatide, Mounjaro is the diabetes drug, and zep-bound is the obesity drug. And they're just, semaglutide is a GLP-1. It's an analog of GLP-1. Tirzepatide has two gut hormones in one injection, GLP-1 and GIP. And in the future, we'll have triple agents and there are many, many gut hormones. And we know that they have many, many mechanisms, but most of them do promote satiety.
I always say semaglutide. I've been saying it wrong this whole time.
Oh, no. I think it's up for grabs.
Tomato.
Literally a tomato situation.
Yes,
I think that you'll hear it different ways. Caroline and I might say it different, just depending upon what sentence we want to say it in.
That's
so I
right.
think that's
I
right.
like the way you say it. It sounds fancier. So one of the big points is that these aren't strange chemicals that we're injecting into our bodies. These are things that are naturally produced by our bodies.
Exactly. I even call them, it's like injecting estrogen or putting on an estrogen patch. It's a hormone. These are hormones. And I even sometimes say, you're taking a vitamin. You're not really, right? It's not a vitamin, but it is an analog of a naturally occurring gut hormone. So we're working with physiology is what we're doing, and we're helping people defend a lower body weight set point in this environment. And we think, and I know we'll have this conversation about the reason why we have an increase in prevalence of obesity in this country and elsewhere is because the environment has changed over the past 50 years. We have much more highly caloric food available. We can, get it anytime we want. We overeat because of that, and then somehow our bodies reset the set point to a higher body weight, most of us. And so this is just working with physiology to restore the deficit, the defect, whatever that defect is. We're not quite sure what happened, but some of us think that there's some kind of a defect or inflammation, either in the gut or the brain, that is not allowing satiety signals to get in, and we're all defending a higher body weight in this environment.
Thank you for taking some of the fear or strangeness out of it for a lot of us. But I think that's a perfect segue to Fatima because, some people are saying now we should consider obesity a disease and not just a state of mind or something like that. What are your thoughts about that?
Well, in 2013, I spoke to the American Medical Association, and it was me that went to the AMA to convince the American Medical Association to acknowledge obesity as a chronic disease. Now, a lot of people realize that that was 11 years ago. And people may not have even recognized that it was 11 years ago that that acknowledgement happened. But why do I consider obesity to be a disease? Because it's a physiologic change. Caroline just explained some of that, but let's talk about what's happening in the brain. There are two primary pathways in the brain that regulate weight. We have an anorexigenic pathway. When we hear anorexia, we hear a pathway that tells us to eat less and store less. That's our POMC, or pro-opiomelanocortin pathway. You can imagine if we travel down that pathway in our brain tells us to eat less and store less. The GLP-1s emphasize or actually augment the POMC, or pro-opiomelanocortin pathway. And then we have another pathway of our brain called the AGRP, or agouti-related peptide pathway in our brain. Now, if we go down that pathway is our orexigenic pathway. Orexigenic is the opposite of anorexigenic pathway. That's our pathway that tells us to eat more and store more. You can imagine if we travel down that pathway tells us to defend or store more adipose. Now, adipose is a fancy word for the organ that is fat. Now, when we think of fat, we just think, ooh, those are people that just eat a lot. But we actually have an organ that is adipose. It's a biologically active organ. Some of us have more things in our brain that tell us to defend or store more adipose tissue. It's not just something that I told myself to do. And so for those of us that have naturally occurring more GLP-1 in our bodies, we travel down that anorexigenic pathway. That pathway that tells us to defend a leaner phenotype or a leaner figure. For those of us that don't have as much GLP-1 in our bodies, you can imagine we store more adipose, which means we appear on the surface to carry more adipose. And when we look at that individual, that person stores more fat. So when we talk about that, you can hear that I didn't throw willpower in there. Can willpower control those pathways? Absolutely not, because if it did, let me tell you, I would have a Nobel Prize to go with that. But I don't. Maybe we should come up with that, you guys. Maybe we'll work together on this panel.
I like that.
But it is not about willpower. It's about the biological mechanisms, the actions that control that POMC pathway and inhibit that AGRP pathway that is the GLP-1 mechanism of action that we're talking about today. So when we get out of this idea of willpower, we get out of this idea of judging people that carry excess adipose, that organ that happens to be one that is characterized by one's storage of fat. Because what happens is if someone happens to carry more adipose, we judge them. Obesity is a disease that you wear. If someone carries more adipose, we assume that they're not exercising. We assume that they eat a certain way. We assume that they're lazy, right? If someone's leaner, we assume that they eat virtuously. Maybe they had a salad today. Maybe they got up and got on that Peloton bike. Maybe they did a workout today. Maybe they went for a swim. But we don't really know. But those judgments set up the most accepted form of bias in today's society. One that allows me to make judgments based upon their size and assume that they are doing something right or something wrong based upon how they look. So that's what I know about this disease process.
I remember interviewing you years ago, and maybe it was 11 years ago.
Oh, maybe it was.
When you told me.
I was 12 years old then.
Yes, we both
Fatima's
were.
a pioneer.
Yes.
Pioneer.
We were kids. It was in
We were both
elementary
kids.
school.
We were 12.
But anyway, I remember, look, I've been reporting on
Yes.
obesity for, I have to admit, for almost 25 years now. And I think it was the first time I had an expert refer to it as a disease. And that was eye-opening to me because all the research I'd done, I'd never really heard that before. And I can't believe that 11 years later, it still seems relatively novel to call it that. And I also have never heard anybody call adipose tissue a living organ. I've never heard it referred to as an organ. So you are on the cutting edge all the time, my dear.
She's a pioneer.
You are a pioneer in the field, and you really are. I mean, you are recognized
really
as
is.
one of them.
Malik, I just want to say
Yes.
one more thing, that today, even today, there are unfortunately people and doctors out there counseling their patients on these GLP-1s that, oh, you know what, you're not going to need that after you get to a good body weight. It's still happening today.
Absolutely.
And it gives us pause because there's so much more education that needs to be driven home to not just patients and the government insurance companies, but doctors need to understand this as the disease that it is. And we're still grappling with that.
And it's important for the public to hear that as well, obviously,
Yes.
that message, so we're not
Yes.
quite as judgy of each other. I am going to turn to Bryn, and you've looked into the role that industry plays in nutrition, particularly supplements. What does that mean? What have you found?
Great. Yeah, and I just want to say how much I appreciate Fatima's remarks about the effect that bias has been having, the stigma around weight, and it's just been devastating. And I'm going to talk a little bit about that. I want to take a bigger picture look at what the context where Ozempic and all of this is happening. The diet culture driven frenzy around Ozempic poured basically gasoline on a dumpster fire of predatory industries profiting off of weight stigma and bias. Exactly what Fatima was talking about. It harms patients. So let's start with the big pharma. These drugs, the GLP-1s, are astronomically expensive. They range from $900 to $1,300 a month. Any health system that tried to cover everyone that was prescribed would be bankrupt. And in fact, our health system doesn't cover 40% of the population who are on Medicaid, Medicare, or TRICARE. They can't get these drugs if it's prescribed for weight loss. A telling study that came out last year found that actually the cost of manufacturing these products is a fraction of what they're selling. Around 20% is the cost of manufacture. All of above that is the profit that they're bringing in. Wow. So now that's the big pharma making the GLPs. Now I want to turn to the kind of predatory companies that are operating out on the margins. So we know there's confederate and compounded versions of these drugs, and I learned a lot from Caroline about the compounded ones that are done in a way that can be very dangerous for people. We've seen just recently there was a study from National Poison Control Center saying that the rates of poisonings because of these GLP type drugs has risen 15 times just since 2019. That is an enormous increase in poisonings. So then there's also what's so-called the Nature's Ozempic. And these are marketers of a supplement called berberine, generally online and elsewhere, promoting the idea that this is a natural alternative to Ozempic. Well, there is not rigorous evidence to show that berberine works for weight loss, but what we do know is that it undermines, it makes ineffective other medications that might be very important that people could be taking. And then this is the most dastardly of them all, is the budget Ozempic. And some of y'all may have seen this on social media last summer. There was such a push for people to use laxatives as a low-cost alternative to Ozempic that it caused a run on it caused a shortage, I should say, on laxatives. A shortage of laxatives because people are buying this. But I just want to say, using laxatives for weight loss is dangerous and it can be deadly. I want to turn for a moment to a real luminary in the field of studying the food industry and their tactics, and that's Marion Nestle, who earlier this year, Marion Nestle described GLP-1s as an existential crisis for the food industry, particularly the processed food industry. I do think that was an intriguing idea, but she's probably underestimating the industry and how skilled they are at morphing their marketing for a changing landscape. And I want to describe 3 strategies that the food industry and the supplements industry are using right now, and they started from day one. One of them is repositioning their existing supplements and foods to say that they are companion products that people on GLP-1s should also use these foods, buy these foods and these supplements. Then another approach they're using is to develop new ultra-processed snack foods to target market to people on GLP-1s and to target market to people who are having to quit GLP-1s because of either the side effects or the cost, and they don't have it covered. And then there's the false claims that that supplements or probiotics can mimic GLP-1s, which they cannot do. They cannot achieve what the medications do. So I just want to say a few more words to wrap up on this idea of taking a step back of how did we get here? How did we get here? So I'll say basically what we have is a food industry, particularly the ultra-processed food industry, that had an outsized effect on causing the so-called obesity epidemic. So then the same food industry steps in and invents the wellness market, the diet market, to sell foods and supplements to people who gained weight because of the products of the food industry. What they're selling is a commodity solution to weight gain. So this is very important for the business model here. And then now we have Big Pharma arriving with GLP-1s to find another way to squeeze profits out of the weight gain caused in part by the ultra-processed food sector of the food industry. So to sum up, I'll sum up the business model of Big Pharma and Big Food. Every problem in their model, every problem can be solved with a commodity solution. These commodity solutions create additional problems, to which there is a new commodity solution to solve that next problem. But for the consumer, this is a house of mirrors.
I just wanted to ask you, you mentioned something about food manufacturers now trying to market to people who are on these medications and people that have stopped taking the medications. How are they doing that? Are they saying, hey, if you are on these drugs or if you stop taking these drugs, this is the food for you? I mean,
Exactly. I get the publications from these industries so I can read all their advice to each other in the marketing language. New tip, you can sell to people who, not even just off GLP-1s, people who are weaning themselves off GLP-1s. They have targeted language they use. They market through social media. Of course, they can very precisely target people through social media and other kinds of publications.
snack foods and things? Or
Snack foods, absolutely. They've got a whole cottage industry in snack foods that they will present as, oh, you need these. If you're on GLP-1s, you need these because you might be losing muscle, so then buy this ultra-processed snack food. If you're coming off of the GLP-1s, buy this other snack food because you need it for this reason, that reason. So they've got it, the marketers are all over this.
so nefarious.
Yes.
This is a great segue. I'm going to bring Uma in. Uma, I just talked about Uma on TV yesterday because she had a wonderful interview with the Harvard Gazette where she talked about some of these tactics that the food manufacturers are using in terms of making things look good and taste good, and they're pretty and they're packaged in bright colors and all those things. Can you tell us a little bit about how sort of nutrition and nutrition advice sort of plays into the market with these new medications?
So I think I think one of the biggest things some of these issues have already been raised by the panelists, but I think that the marketing of the food industry has always been an issue. I think it's for really putting the onus upon us as the consumers, even if some of us are physicians, to actually understand what they're doing. And, you know, to Brent's points, they are always marketing. So here's a simple example. Fast food French fries, some of the brands contain sugar. Research and development of those food companies has taught them that the addition of sugar, which you can't taste in the French fry, but do you ever wonder why you buy the bigger size, and then when you buy the bigger size, you eat all of it, even though you might have thought you would order small, and then the next day you're thinking, that lunch was good, maybe I need some more. these foods are engineered in a certain way. So nutrition is problematic in sort of the medical sphere because most doctors are not fully trained. Do not learn nutrition in medical school. You have to learn it in other ways. And those, obesity medicine doctors and individuals like that, I think, understand a lot more and have learned a lot more. But the average physician is not going to give you that advice. So an example of where nutrition goes really bad is a patient seeing me for a nutritional psychiatry consult brought in her little daughter and said, Dr. Naidu, I remembered what you said about fiber and whole grains and nutrients and vitamins, and I saw the cereal and I bought it for her. And the cereal actually was ultra processed, had a lot of sugar, but had a tiny bit of whole grain. But this is where marketing, food labeling, they all stay within the law because these are monitored, but they actually give the consumer the wrong impression. So here she's eating the cereal, but it's not the healthiest choice for her. So it's all of these things that play into it, and I think what I see a lot of in the work that I do is the fact that the obesity epidemic, the problems of our food industry are also impacting our mental health, and that's a niche gap that people haven't really connected. And the work that we're doing in lifestyle and nutritional psychiatry and metabolic psychiatry is bringing that forward to show that it's not just the diabetes or hypertension or the other conditions you hear about from your doctors that you should worry about. You should also worry about it for things like depression and anxiety. Anxiety, as published in The Lancet, increased by 25% worldwide after the pandemic. So if you're wondering if a colleague, co-worker, friend, family member is more anxious, it's true. Are there ways to use nutrition? Absolutely. So I think it's just about providing more solutions and us being more savvy about what food lobbyists and food marketing and the industry is doing.
We're talking about your patient and the daughter with cereal. I remember when I was growing up, my parents used to always say you can get whatever cereal you want as long as the first ingredient is whole grain or whole wheat. But Captain Crunch fell under that. So I ate a lot of Captain Crunch cereal.
How is that even possible, Uma? How is that even possible?
Well, they're so savvy. The food industry is so savvy. There are 262 other names at the last count for sugar. Using a different name for sugar on food labels. A great example is brown rice syrup, because people associate brown rice with a little bit more whole grain. Brown rice syrup is simply sugar. So there's these clever ways of not really informing the consumer of and that's why I feel like we need to learn a little bit about food labels. That 4 grams of sugar is 1 teaspoon. Our recipes are not in grams, so we don't really understand what 4 grams is. So having a mom or having whoever's shopping for the family understand a few things like that is helpful, because if not, we get tricked. Whether it's Captain Crunch or
I couldn't have crunch berries because sugar was listed number 1.
And this happened early, this happened in the 50s and 60s, right? I mean, I remember as a little girl looking at TV and hearing the Lay's commercial. I bet you can't eat just one, right? That was the industry.
And Uma, I wanted you to address that too, about sort of how you get into this vicious cycle. You're stressed, you're anxious, you tend to eat more. Those foods trigger the pleasure centers. How does that work?
So as everyone has pointed to, this connection is also with the brain. There's so much that goes on in the gut. There's a connection between the gut and the brain, and it's one of the mechanisms that helps us understand this mood-food connection. But specifically, stress, people talk about stress eating and things like that. Stress precipitates habit circuits in the brain. So if you are stressed and you go get that fast food lunch or whatever it is, you will naturally, your body will want more of it. Your brain is engineered that way. There were studies done on street drugs like cocaine, and they showed that sugar, which is one of the big offenders within ultra-processed foods, works in the same dopamine reward pathways in the brain as street drugs like cocaine. So when people say they have a sugar addiction, it may seem like a strong word, but they are literally sitting in front of you struggling with that. And it opens up these pleasure pathways. You just want more of it. You feel good and you just want more. Unfortunately, in that moment you may feel good, but the long-term effects in the brain have been shown. Not just the obesity piece and the weight gain and all of the disruption of our metabolism that happens, but also affects your brain. So these are, those subtle ways that we that we're struggling.
So let's talk a little bit about how people feel in their own skin. You were going to mention something about body positivity.
Yeah.
What do you mean by that?
Yeah, and I appreciate, Emily, bringing up that the onus ends up on the individuals trying to navigate what the industry is putting out to them. Body positivity, we've all heard about this. I mean, it's basically a simple idea that people of all sizes and shapes should be accepted, valued, and treated with dignity. Now, this is a good idea on its face. I mean, it sounds great on its face, but it's a bit of a chimera. And I say that because body positivity, for the most part, has been pushed out, mainly focused on encouraging individuals to feel better about their own bodies. The main focus has been on individuals. Well, this has been without also taking putting a focus on taking steps to address the larger systems and structures that are really driving the body negativity, if you will, if you could put it that way. And I think this myopic focus on the individual there has really served up body positivity to be repurposed by these mega marketers who can then parlay it into profit for them because they're commercializing the idea of body positivity for their own financial gain, primarily by selling services and products to girls and women, because they're the biggest consumers of these kinds of products that are pushed out that way. Well, what it also does, the focus on the individual, is diverts vital attention and energy away from the structures and the systems that are some of the main drivers of body dissatisfaction, of weight discrimination. And these are the diet industry and discrimination in the law, weight discrimination in the law. And we're sitting in a public health school. I want to really drive home this point that weight discrimination is a social justice issue. Every body deserves to be treated with dignity. And this we heard right from the start, Fatima's remarks there. But the truth is, almost everywhere in the country, it is perfectly legal to discriminate against people based on weight. There are only a few cities and a couple of states that have any kind of protections at all. I've done some back of the envelope calculations, and over 90% of Americans live in an area where tomorrow their boss could fire them because they don't like their weight, and there was absolutely nothing that they could do to object to that. Nothing they could do. Well, from a public health perspective, we really put a premium on social justice and health equity. But there's really been, in the public health field, a real disconnect when it comes to the unfair treatment and the foreclosed opportunities that people living in larger bodies experience. These forces around weight discrimination, they're very intersectional in that they're compounded with racism, with sexism, with economic marginalization. And these have devastating impacts on people's health and their life chances. My group, Striped, finished an economic study recently where we estimated the cost of weight discrimination to the U.S. economy. Now, this is not the cost of obesity to the economy. Those studies have been done. This is the cost of weight discrimination. Our estimate, $200 billion, that's billion with a B, $200 billion a year is the cost of weight discrimination in this country, and it's a recurring cost every year. If any people interested in this, we have our report is up on our website. It's from our study, The Real Cost of Beauty Ideals, on our website. You can read more on how did we do it, because I'm sure people are wondering, how did you do that? So I just want to make a final point. I think this is where the rub is. When we allow weight discrimination, stigma, fat shaming to continue unchecked, we're creating the conditions where Big Pharma can deploy new drugs like GLP-1s in a way that further exacerbates inequitable access to health care. I mentioned that 40% of Americans have kinds of insurance that won't cover GLP-1s if it's prescribed for weight loss. So it exacerbates inequities in healthcare access, and also, while doing that, generating astronomical profits for them, not for the rest of us, but for them. And all of this while these drugs are being touted as the holy grail for all that ails us as a society.
Again, you've given me a perfect segue because I want to come back to the drugs.
But I want to talk about real life issues and real life patients, and I wanted to give you actual patients. She gave you the context of what happens, and I'm going to talk about a real life patient of mine that came into me a patient with very severe obesity. In the context, I don't really like BMI, because it's a racist and sexist measure, but we'll talk about a BMI of greater than 40 being characterized as someone with severe obesity. So this is a patient with a BMI of close to 60 that came into me. And when she first came into me, she talked about not being able to be hired by a local employer here in Boston. We worked together. She underwent several treatment modalities, which included lifestyle, bariatric surgery, and the use of medications, which included GLP-1s. Over time, with these therapies, her BMI went from that BMI of actually 57 to a BMI of 26. So we would say that's a major shift, right? I think that we would agree. Same person. She happened to be a Hispanic woman. Went into the exact same employer, no additional training, no additional education. So she's an N of 1. For those of you who are researchers, you guys know that that's not really significant, but she's the N of 1, went into the exact same retailer, no additional training, same exact job, was hired on the spot. Okay? No additional training, no additional anything, was hired on the spot for the exact same job. So why was she hired? What was different about her? What did we talk about earlier? Her aesthetics changed. Her health changed, yes, but they didn't have her medical record. I did. She changed because she looked differently. She was viewed differently. The $200 billion number that was just quoted by Brigham accounted for the lost wages that she had over those 2 years. She had 6 children that she had to feed, that she was now able to feed. She went back into that employer a few months later and she said, I just wanted to let you know that I came in and I tried to get hired for this job and you didn't hire me. And she felt comfortable with saying, now you hired me. But I want to let you know that I think the reason why you didn't hire me was because of my size. And the woman's mouth fell open. That is the real life circumstances that these people are dealing with. And I said these because I am not a woman that's lived in that size body. I am a Black woman. The other most common form of bias, race and weight bias, the 2 most common forms of bias here in the United States. The compounding bias that we talk about, imagine if she happened to be a Black woman with obesity. These are real stories. Now imagine, and I will give you another story. She comes into the office and she wants to be seen in an obesity clinic, right? I treat patients exclusively with obesity, so does Caroline. And she comes in and she doesn't even have a chair that has an appropriate seating mechanism, because that happens in a lot of our doctor's office. They don't even have a seat to sit in and they come down and they want to get a seat, but there's not a seat appropriate to sit down. So they just stand up in the waiting room. The office staff tells them, oh, have a seat, but they can't sit down. And so they stand in the waiting room because they don't have a seat to sit down. And then it's time for them to get weight. But guess what? The scale doesn't really go up to the weight that's appropriate for them. So then the staff is laughing because there's not an appropriate. And guess what? Then the blood pressure cuff isn't appropriate. So then they get back to be seated because then they have to wait for us to get back there. And guess what? The exam table isn't appropriate. And then it's time for them to put on a robe. And guess what? There's not a robe that's appropriate. So they've gotten so many nonverbal cues that they don't belong in the healthcare environment that's supposed to take care of them. The structure is not set up to care for the patients that we're supposed to care for. That is the problem with the system. That is what happens every single day. And I hear it time and time again from our patients.
I did a story not too long ago about a clinic out in Needham, Massachusetts, who aims to treat people of all shapes and sizes, and they did. They had larger seats. They had scales attached to the chairs in the offices that would weigh them, so they didn't have to feel humiliated getting on a scale and hearing what the recent number was. So I was so pleased to see that someone was trying to address that, but as you know, the vast majority of places can't accommodate people of a certain size. I want to get to, and maybe launching off of the patient that you described, how did she get access? How did she get these drugs paid for? Because we know a lot of times the people who need these medications the most are not the ones who are getting them. So if Caroline and Fatima could talk a little bit about access and racial disparities as well when it comes to access.
Yes, so Bryn just quoted 40% of Americans don't have the type of health care that will cover anti-obesity medications. And when you think about the fact that 42% of American adults have obesity, I would garner that it's many of the patients who have obesity who do not have the kind of health care that will cover the costs. So Medicare, as we know, does not cover anti-obesity medications. And now you have to have, for Medicare to cover, you have to have had a heart attack or a stroke or peripheral vascular disease for Medicare. So everyone over age 65, you're out of luck for the most part. And then we have Medicaid, and in certain states, they started to cover anti-obesity medications. In this state, they do now, as of January, but there was a good several years that they did not.
But I want to put a caveat to that. The copays associated with coverage under Mass Health are so cost prohibitive that many of my patients still cannot afford.
Still can't. That's correct. That's correct. Good point, Fatima. So then we have, we talked about Medicare, Medicaid, and now the private insurers. Our team did a little data analysis of our group. Last year we saw 12,000 patients, and of the patients who had private insurance, Blue Cross, Harvard, Aetna, Cigna, 60% of those had coverage for anti-obesity medications. Mm-hmm. Only 60%, okay? So that means 40% don't. And you can see where those of less socioeconomic status are going to end up with insurance companies that are not going to cover. And it's those Americans who have lower SES status who tend to have higher obesity rates, and we can go and talk about why that is. But the punchline is, affording healthy food is very difficult in lower SES groups. So, and that's part of it. That's part of the toxic food environment and ultra-processed foods and the easy availability and low cost of marketed ultra-processed foods.
And if I could just link a point, I appreciate you walking through that. So for the folks who can't afford the copay or who their insurance won't cover it, and financial reasons they can't just buy it out of pocket, they're also being preyed on by what I described as the so-called nature's Ozempic, the so-called budget Ozempic, the compounding. And then you told me about how dangerous those are because they're lower priced, but they are also more deadly.
Very dangerous.
And that's where the folks are looking for. They feel the pressure to find whatever they can that's like a GLP-1 in their minds because they're being told that. But it can be downright dangerous.
Do you see improvement on the horizon? Do you see, drug manufacturers are saying that they're trying to increase production to address demand. Do you see that a year or two down the road that there is going to be some relief?
Well, there'll be increase in production, but we're dealing with, in the business world, a blue ocean strategy. We have over 1 billion people worldwide with obesity, and those numbers are increasing, right? We haven't really seen a strategy that's seeking to really improve access. If we look across the northern border, we talked about the prices of these drugs here in the United States, but if we go across our northern border to Canada, the price out of pocket for semaglutide, semaglutide, whichever terminology you want to use, is $278 for the exact same drug in a country that has similar economics to us here in the United States. That's a significant difference in price point than what we're paying here in the United States for the exact same agent. The tirzepatide cost, I'm not sure even if it's actually gotten full approval on what their cost of it is there, but when we were talking to our colleagues, Sean Morton's and colleagues that are practicing there, that's the price point, the government negotiated price point for that agent from the exact same company. So why is there such a disparity in the cost? It's because we're not somehow negotiating for that price point when the need is significant here in the United States. Now, we're not saying it's not significant elsewhere. We know that the need is significant throughout the world. If we're looking at this from a worldwide viewpoint, I was just at a conference at the National Academies of Science and Medicine, and we're seeing also that these medications aren't just useful for cardiometabolic needs. This conference was looking at the impact on CNS disorders, Alzheimer's, Parkinson's, dementia, substance use disorders. So what we're going to see is that this actually is going to worsen over time as the utility of these drugs across disease processes increases. The demand for these agents, even as more manufacturers start to come on board, is going to increase the need for these drugs, and which groups are also impacted by those disorders. Still the same groups. So I think this is going to continue to worsen, and the equitable access for these drugs is going to continue to worsen over time, unfortunately.
But Fatima, I'm starting to see in social, not really social media yet, but in the literature, this explosion in thought that if we get access to these life-saving therapies for most people who need them, we are understanding that down the line, the healthcare costs for heart disease, for diabetes, for stroke, for osteoarthritis, for everything, for mental health disorders, is going to drop. It's finally starting to infiltrate out there, and the thought process that says, okay, if we provide access to these life-saving therapies, if we somehow get together, government, the industry, pharma, doctors, hospital systems, and say we're gonna cover this, and in order to get the gold ring, decrease in healthcare costs worldwide, that's where we have to get there. And I'm starting to see that.
So you're the optimist.
I know. Good cop.
That's the
bad cop.
optimist. Okay.
Optimist, pessimist.
Okay.
Slowly. Listen, we only have 3 minutes left.
Okay.
Okay, and we have covered so much. I'm really happy with what we have been able to discuss. Of course, there's tons we weren't able to get to, like substance use disorders and other things that these drugs might be used for. I give you each 30 to 40 seconds to tell me what advice you would give to people out there who are considering these drugs or maybe recommended these drugs, and maybe someone can touch on side effects or long-term complications, or like what would just in a nutshell, what advice would you give to folks? We'll start with you.
My advice actually is for people who think it's wrong that there's weight discrimination almost everywhere in the country. So actually what I would say is we need collective action. There's a campaign for size freedom. Be part of this. We can change the law so you can't be fired tomorrow because of your weight. In my own program, Striped, we have the Out of Kids' Hands campaign, which is banning the sale of toxic over-the-counter diet pills to children state by state. We've already passed the law in New York. It's collective action where we'd also be able to change how the reimbursement and the setting of the pharmaceutical prices. It's lobbyists who got them set so high in the U.S. and low in Canada. We need collective action to address that issue too.
Awesome. Caroline.
Great. I would say to patients, to people thinking about these life-saving medications, go to your doctor and don't let your primary care say, I don't do that, or I go to your doctor. And I've counseled my patients. They've come to me because their doctor wouldn't prescribe. Go to your doctor and tell your doctor, I have a disease. I have tried everything I could, Weight Watchers, Jenny Craig. I know this is a disease and I need this medication for my life. And don't back down, because that doctor will listen. That doctor will indeed listen, because it's all over the place, all over the medical journals. And only it's a grassroots movement that patients have to start. And eventually the doctors will prescribe. We need more primary care providers to treat obesity.
Advocate for yourself. Uma.
So with mental health, the medications that I am often needing to prescribe themselves cause a lot of side effects, which is one of the things that led me into really bringing forward nutritional lifestyle and metabolic psychiatry. So I think people need to understand that how we eat and our lifestyle choices, while we are waiting on whether we are eligible or can get a medication, there are other things we can be doing. I want people to really think about feeling empowered while in that phase and seek consultation from those who can help give you some, say, nutritional therapy, some lifestyle, even things like better sleep can help you in this phase as you are deciding on the right treatment with your doctor, especially if you don't have access. And just remember that nutrition and how you are eating, separate to the medical condition of obesity that you might have, will also be impacting how you feel emotionally. So it's all connected, right? Mental well-being and mental health is not an above-the-neck concept anymore. It's really integrated with the body. So try to hold on to that as you navigating what you need to do.
And Fatima.
And I would say that obesity is a disease. If you happen to have the disease, it will show up differently in every single person. If you have it, you matter. You don't mean that you're different than anyone else. It's okay. If you happen to be a racial ethnic minority with disease, it's okay. There are people out there that will treat you for the disease, and we will treat you with the variety of treatments from lifestyle to pharmacotherapy to metabolic and bariatric surgery, but it has to be treated over the lifetime. There is no magic treatment. GLP-1s may be a treatment that works for you, but they may not be the treatment that works for you. There's heterogeneity in treatment across the life course. Recognize that you matter, you deserve treatment, and we're here for you.
Bryn, Caroline, Uma, Fatima, thank you so much for joining us today. Thank you for everybody who's in the room with us. Thank you everybody who's on live stream. That's the end of our meeting.
Thank you.
Thank you. Pleasure.